that was when the medical practice was, let's give opioids so that we can treat pain because this is what's best for patients. And I felt like, nursing care is sort of teed up that same way, where especially when the patient satisfaction surveys came out and they asked patients, how often is your nurse treating your pain? That set us all up for, okay, we got to just treat, medicate. And we're not really thinking outside of the box of how can we manage the pain, but without causing so much havoc on the backside.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now it's time to roll back and start the first case.
On this week's episode of the First Case podcast, we're speaking with Jessica Hovland, registered nurse and the senior director for UT Health Austin's Ambulatory Surgery Center. And so far in this series, we have highlighted the opioid crisis. We have seen the connection between postoperative narcotics and addiction. We've looked at regional anesthesia, liposomal bupivacaine, and even talked about the unique issues affecting our pediatric patients. But today, we're going to switch gears and look at one of the many non-opioid methods that are available to reduce pain and anxiety in our surgical patients. So stay tuned. We'll be right back to discuss virtual reality with Jessica Hovland.
Hi, I'm Chris Blevins.
And I'm Melanie Perry.
From the studios of Healthcare HQ, you're listening to First Case.
Joining us now is Jessica Hovland, registered nurse and the senior director for UT Health Austin's Ambulatory Surgery Center. Jessica, welcome to the show.
Thank you so much for having me, Melanie.
I'm really excited to be able to get to talk to you today because I met you at the 2023 OR Manager Conference, and I was in your presentation where you talked about your DNP research and how you were blending multimodal analgesia and virtual reality so that your surgical patients could have a non-opioid treatment option for their postoperative pain. Very innovative approach. And I knew that we needed to have you as a guest on this season where we're talking about the opioid crisis and pain management and those non-pharmacological options. So why don't you go ahead and just kick us off by telling us a little bit about yourself and a little bit of your background?
Sure. Hi, everyone. My name is Jessica Hovland. I am a nurse by trade. I've been a nurse for over a decade now. And I originally got my bachelor's in nursing and, went straight into the hospital setting. I really wanted to get my experience and get that bedside nursing experience. And so I started off as an advanced brain and spine nurse and then made my way down eventually into the PACU unit where I found my passion and my just overall joy as a nurse. I really liked being in the perioperative setting. And at that time, I was a lot younger and I could handle working a full-time job. And then I also had some side gigs or side hustles. And so I was picking up a bunch of different jobs on the side and found a director of nursing job. It was hard for me to really jump into that role because I felt like I didn't really know it very well. As a leader, I wasn't really taught all of the hard and soft skills that you need to be in that role. And so that's what ignited my journey into getting my doctorate degree. So I ended up going back for an accelerated doctorate degree, bachelor's to DNP, and focused on nurse executive leadership. Fast forward to 2020, I was finishing up my doctorate project, and that's why I'm here today, is to tell you all about my DMP project and how we got to sort of design the way we provide pain management in the perioperative setting.
I really think that it is so cool that you chose virtual reality and pain management as your DMP project. So far this season, we've talked about a lot of different things related to the opioid crisis, related to how we are medically managing pain for patients to avoid narcotic prescriptions, which would then prevent narcotic abuse. But we haven't touched on anything that was a non-opioid treatment until we're talking to you today. You're our first one that's a non-opioid method for managing pain. So I want to kind of start at the beginning. What made you decide to study VR in your research for your DMP?
I wanted to focus on something that could give me passion to finish my DMP degree first and foremost.
You got to give what you can.
Yes,
do what you can.
I needed the motivation, but I also wanted to make sure that it applied to my practice. And when I was thinking about what type of change could I implement and how could I get everybody on board to help support me in this project, because it was a big one, right? And I knew that there were multiple stakeholders from different departments that I had to motivate to do something different, especially with VR, right? It's like a nascent technology to a lot of the nursing world, especially. And when I was thinking about what is it that is going to drive me to the end, VR was one of them. When VR came up, and I actually had the opportunity because of Dr. Robert Lewis at the time. He was a neurosurgeon at the hospital that I was working at. He was working on getting the hospital to be a dominant force in the extended realities market. And he wanted to deploy VR in several areas of the hospital. And I just so ran into him one day and was like, hey, would this be appropriate to put in the PACU area? I think this would be great. And he was like, yes, let's do it. And so that's where it all started, was with a physician champion sort of backing me up and helping me get it off the ground.
So I'm glad you told me who your champion was, because I was actually going to ask, who did you get to be your champion? But beyond that, you did have to get buy-in from a lot of other people. How did you go about getting that buy-in so that you could start your research?
The easiest way to get the buy-in was just to put the headset on everybody. So
there you go.
It was so much fun because I remember taking pictures with my phone, and, we started with the nurses, which was so fun because it broke up their stressful day, right? And we could say, hey, come over here. We're trying out these headsets. I want you to see what this is all about. And so they would sit in their office chair and do like a 360 spin with the headset on. And it was just immersing them into a whole new world was something. It was just magical to see.
Yeah,
and
sure.
then on top of that, then, being that we're in the perioperative setting, we have doctors passing by all the time, passing our nurses station. And so then we got the surgeons try on the headsets and the anesthesiologists try on the headsets. And that really sparked interest from the get-go of, hey, look at how cool this technology is. Wouldn't it be so amazing if we could put this on our patients while we're providing care?
So then tell me, what was going on inside the headsets? What were they watching?
Yeah. So one of the favorites was swimming with dolphins. And it was like you were a scuba diver underneath the ocean, swimming with dolphins. And you could hear the dolphins sort of singing.
Oh, I'd love that. Yeah.
Yeah. It was very calming. And you heard the movement of the ocean. There were other modules that we had where they could pick a certain country that they wanted to visit. So they could go and ski in the Alps, or they could go to London for one day and just be a tourist, kind of breaking up the day of, man, I've got so much to do, but then let me just take a quick break and take a tour in London. That was awesome.
Yeah, sign me up. I'll do it. Yeah. Now, were there game options too for other patients if they were interested? Were there games they could play, or was it all imagery type?
There
technology?
Were games. There was one game. It was like a ball shooting game where you could score points and, with the turn of your head, you could hit targets. So,
fun. Okay.
It was, there.
I'd be sitting there tossing my head back and forth, playing the games. I know me. That's what I would be doing. After I swam with dolphins, I'd need to go play a game. Wow. But yeah, just the fun nature of it, but also the distractive nature of it and the way to just do something calming. I can see already so many benefits to just taking some time to relax and be distracted and get out of the environment that you're in, right?
Right. So the distracting technique, right, can play a part in how you manage your pain, but it can also play a big part in your anxiety as well. So a lot of the studies, when I was looking through them, there were already studies where they were looking at VR for treatment of burns or, distraction while they're doing dressing changes. And they found that VR is actually more effective at treating pain than the other traditional approaches to distract a patient by using like television or music, because you really are taking away what's actually happening and replacing it with something different in your brain.
You're being immersed into it.
Right.
And as somebody who has played on my kids' VR and I've gotten completely immersed in any of the games that I'm playing, and you just feel like you're in a different world. I mean, it's kind of fun as when we're not the ones playing to watch the people who are playing, because you don't really realize how funny you look, right? But you're so immersed in what you're doing. And I have enjoyed the VR from that standpoint. But to think about how well it could help our patients is it's mind-blowing. So I want to hear, how was your study set up, or what was it really that you were looking to learn from in your study?
Right. So when I was a PACU nurse at the time, I felt like, it was the traditional approach to surgical pain management is to typically load patients up with narcotics, right? They can't eat right away because they're potentially going to get nauseated. Want to be able to treat their pain right away and make sure that they're comfortable and they're not waking up with a bad experience. And I just felt like, man, am I the one though contributing to the opioid crisis? Like, I understand that this is a temporary solution. I'm taking care of them as best as I can in the recovery room. But what is the aftermath of that? How is this patient going to treat their pain after surgery when they get home? And so when I was reading some of the studies, it's just really interesting. But let's say a patient has never had narcotics before and they're opioid naive. They've done a study where they found that 10% of those patients become chronic opioid users after 1 year after their short stay surgery. Yeah.
Man.
Even going back to the history of the opioid crisis when the FDA had released OxyContin as this low risk for iatrogenic addiction, they marketed as something that's good for non-cancer pain. I mean,
the wonder drug for pain, right?
Right. It's just like, that was when sort of the medical practice was, let's give opioids so that we can treat pain because this is what's best for patients. And I felt like, nursing care is sort of teed up that same way, where especially when the patient satisfaction surveys came out and they asked patients, how often is your nurse treating your pain? That set us all up for, okay, we got to just treat, medicate. And we're not really thinking outside of the box of how can we manage the pain, but without causing so much havoc on the backside.
Yeah, absolutely.
Right. And so I just felt like I needed to do something, and knowing that VR, and at the time we were really into ARIS protocol and multimodal analgesia. And so, how could we blend those two together and really create a better experience for our patients?
So at first I have to throw in my own little tidbit of history related to how we were taught to handle pain, quote unquote, back in the day. But when I went to nursing school 22 years ago. So I am dating myself here quite a bit. But when I was in nursing school, I was taught that you cannot get addicted to pain medicine if you are taking it because you are in acute pain. You will not get addicted to it. And I thought that for a long time. And I would even tell my patients that, don't worry, you cannot get addicted to it. You're experiencing acute pain. This is what it's for, and you're not going to get addicted. Don't be scared. And yet we're finding, and more research coming out, that is not true at all. But we were taught one thing and now it's being proven wrong, which, I mean, that is the nature of medicine and research and science. We think something, then we test it, we learn and we move on and we hopefully change and for the better, right? And so I've found by interviewing you and then some of the other people for this season, all of the ways that research and that understanding of pain and addiction and how patients really can become addicted very quickly to these medications has driven change and driven research and studies to make it better with non-opioid methods. And one thing I'm curious about with you, because you actually mentioned that you did this in 2020. So obviously COVID, right at the beginning of COVID, and here you are doing a research study. How did COVID affect you doing this research?
Oh man, I was, again, determined to finish my DMP. There was nothing that was going to stop me, right? Yeah, and it just so happened that it hit right at the last year of my program.
Oh, wow. You just have to keep going.
you just have to keep going. But that challenged me because we really had to focus on the cleaning protocols of the VR headsets and making sure we had a robust way of pivoting and making sure that this is not going to be the barrier to implementing this project. But so we implemented, Sani wipes, and then we also found a company that did some UV light technology to clean the headsets. Post pandemic, I don't recommend that. I think that's overkill now at this point. But we had to figure out at that time, how do we make sure that this is going to be, safe for our patients, safe for our staff, and also doing it in a way that, people are still open to using the technology.
Yeah, you want them to be willing to put something on their face that is obviously a reusable product. And so they need to know that it is not going to get them sick. With everyone being so afraid of how they could, contract COVID, I can see that being a huge issue for people until you told them how you cleaned it and they were okay. I can wear this.
Yeah. I think that made people a lot more comfortable after we added that extra layer in. And so, we still did everything during the pandemic.
Wow,
we were able to educate the staff in small batches and make sure that the PPE was there if they needed it. And we just kept going.
Okay. All right. So now I want to know, patients, were they using the VR headset? Were they using it pre-op? Were they using it in surgery? Or were they using it post-op? Or kind of a mixture of all of them? What was going on?
Based on when I was doing my research and I was looking up the evidence-based literature, part of the process to talk about pain management with the patient is to involve them in their care, right? And to make sure that they can advocate for themselves and make choices for themselves to treat their own pain. And we had developed the program so that way they were immersed in the technology in the pre-op area. So they had a test run, right? We didn't want to throw the VR headset on them after they'd had anesthesia, and then they would probably freak out, right? Like, what is this on my head?
We don't need any more reason to be disoriented or combative. So we don't want to do that.
So it was nice to say, hey, would you be interested in being a part of this program? We'd like for you to test run it, put it on for 5 minutes. Let us know what module you prefer. We will let the PACU nurse know that you would like to go swimming with the dolphins after your surgery, and we will write that down. And so it was actually a great experience for the patient up front because it helped reduce their anxiety about this big procedure that they were about to have. And we were focused on the robotic hysterectomy patients. So you can imagine the amount of anxiety of the female patients, going into such a huge procedure. We ended up finding that there were other benefits to the VR technology after that.
Well, that's what I want to know. So what benefits did you see and what were the results of your research?
So when we were putting the headsets on the patients in the pre-op area, we found that not only was it good to help reduce their anxiety, it was actually helpful to distract them from the pain that came with the IV start. And that was a pleasant experience for the patients. And they had multiple comments come through about that. And so after they had the VR headset trial run in the pre-op area, then they have their surgery, right? And afterwards is when in the PACU is when the nurses would put on the headsets if they were experiencing pain. Now, unfortunately, the way that we did it in the time frame that we had because of the DMP project, we were unable to find a large cohort of patients to study. And so we weren't able to see a statistically significant difference in the amount of opioids that they were consuming. However, when I started to take a look at the data, one of the things that I noticed in the pre-implementation group was that the adherence to the ARIS protocols and the administration of multimodal analgesia by the nurses in the pre-op area was pretty bad. And 67% of the patients didn't get those PO medications. But after we implemented the program, every single one that we studied got the medications. And so what ended up happening was we didn't have a chance to utilize VR as much as we could have because their pain was being controlled so well by the multimodal analgesic medications.
But you were seeing the effects of the ARIS protocols and all of the things actually being put into place and working like they're supposed to, right?
Right. Yeah. Which was a great thing. So, I mean,
yeah, surprise.
They weren't, the opioid consumption didn't change. They were also getting better pain management, right? And that was great to see.
No, that is good to see. It's surprising what you do find in a research study that's just extra or, that just happened because you were doing it too. And obviously we understand that COVID and the effects of that probably had to do with, the limiting number of patients that you were able to include in your research. But I'm curious, are you still using VR at your facility today?
So I currently work in the heart of Austin now. I'm no longer in California, but I am working at an ambulatory surgery center that is just starting to get up and running. And we've been open now for over 3 years, but we're starting to expand more and more. And one of the strategies for marketing in the future, hopefully, is to implement another VR program. But I want to take some of the findings that we had from this first DMP project and really implement them into the now. And that is focusing on the preoperative area and all the benefits that we had heard about from our patients. I actually ended up bringing some VR headsets with me to Texas and just told the nurses about it. And I had walked by the nurses station the other day and found one out, and I was like, "Hey, are you using this headset? What's going on over here?" And the pre-op nurse was like, "Yes, yeah, I'm using it for the pediatric patients. I'm using it for the patients that are scared of needles. It's just been a great way to help distract people, and especially when they're anxious or they're scared and they're stressed about their surgery." So that was really cool to see. I think
for sure.
That's where we're headed is focusing on the pre-op area and talking about what is the patient experience from the front end and how can we make sure that they're well cared for throughout the whole stay.
I like the overall complete approach to the patient experience, not just focusing on, one part, either pre-op or surgical or post-op, but how can we improve the overall patient experience? How can we improve the overall anxiety or pain of our patient and really see them holistically and care for them from the minute they walk in the door, until we see them for their follow-up. But I like the idea of, and I think that's the way it should be, really caring for the patient as a whole. As we come to the end of our interview, what do you see as the future of VR with our surgical patients? Where do you see it going?
I envision VR being one of those anesthesia types on our surgical orders.
That'd be great. Yeah.
Right? Like if we could have local VR, MAC in general.
Yeah.
That would be amazing. And then having a menu for the patients to look through and say, "Hey, you know what? I'm having a really bad day because I'm about to have surgery. Can you please take me to a beachside vacation?"
Yeah. Rather than just telling them to think of a beach, actually letting them see the beach and the relaxation of the waves and all of that.
Yeah.
For sure.
I just think that you talk about the holistic side of patient care, and the mental health aspect of it is so important, right? But then also for the nursing staff too, to know that they're a part of that journey, and they're really providing a significant impact to the patient's overall health. Like it just doesn't get better than that.
No, it really doesn't. And I think that is a great way to bring this interview to a close, is it just doesn't get any better than that. So thank you so much for taking the time to talk to us today, to tell us about your research study and to talk to us about VR. I'm so thankful that you joined us for this episode.
Yes. Thank you so much for having me. It's been a pleasure.
Oh, it's been our privilege. Thank you so much. That was Jessica Hovland, registered nurse and the senior director of UT Health Austin's Ambulatory Surgery Center. And despite the challenges that COVID presented while she was doing her research, she was still able to put her ideas into practice, to test her theories, and she saw real results and benefits to the patients and the staff who were using virtual reality. And when we look at diversions like virtual reality, they help to decrease pre- and postoperative anxiety, and they can also reduce postoperative pain, which gives us yet another tool in our arsenal to combat the opioid crisis by incorporating virtual reality in our patient care. And that is going to do it for today's episode. So on behalf of all of us here at First Case, thanks for listening to this week's podcast.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.